Welcome. This is the in-service for the V60, the non-invasive ventilator. This is the successor device to the Respironics STD and the Respironics Vision. The primary advantage of this machine is that it can be used for transports. Okay, so there's an internal battery that is good for, it can run up to 6 hours. Make sure that the machine is always plugged in, even when not in use, so that the battery can stay fully charged and conditioned. Okay? Now, in addition to the battery, it also includes the transport yoke. Okay? The center hose would hook up to your 50 psi source on the wall on oxygen. There's an internal turbine or blower that takes room air, so mixes your FiO2 through a proportioning valve. Then you can hook up 2 E-cylinders. The hose goes into the auxiliary port on the E-cylinder, and then turn the E-cylinder to the auxiliary setting to supply 50 psi to the V60. Only run one at a time. You can hook 2 tanks up, but only run one at a time. Okay. It has a diaphragm type regulator in there, so it draws equally out of both cylinders. And so when you get to a low FiO2 or loss of gas supply alarm, don't think, well, I have another one, because you don't if you've got them both on. Okay? The V60 in transport mode on an E-cylinder uses quite a bit of gas out of the E-cylinder. So if I have a situation where the patient's drawing a volume of 500 cc's with an IPAP of 18, an EPAP of 6, a respiratory rate of 20, and a mask leak of 20 liters a minute, if the patient's being transported at 100% FiO2, the E-cylinder will last for 15 minutes, 15 to 18 minutes. Okay, so go fast. Now, with those same parameters, but an FiO2 of 30%, then the E-cylinder will last for almost 100 minutes. So a big difference there. Now, if the patient is stable, then why would you have them on this? But if the patient's stable and on 21%, you don't need an E-cylinder at all. The internal blower will supply the sufficient FiO2. Okay? Any questions on that? Now, one of the things I did not like about the Vision was that the on switch was behind this little plastic door that was butted up against the oxygen module. So I wasn't able to just reach behind and turn it on. I always had to squiggle my way to the back of the machine, flip the door, and turn the switch on. On this device, the on-off switch is right on the front line. It'll go through a minute of self-diagnostics. When the screen comes up, it has, it's a true touch screen, okay? So all these are touchscreen buttons that can be activated. There's 1, 2, 3, 4, 5 parts to the screen, 5 panels. And I'll describe each one of those individually. Good. The top one is your alarm silence, alarm reset, and an information bar giving you information about what the V60 is doing. The second part is patient parameters. It measures what the patient's doing. The third part is a shared panel with graphic waveforms, which are very functional on this device, unlike on the Vision, for instance, and historical messages. The message bar at the top right-hand corner gives you current alarms or information. Then historical data is stored in here, but it cuts off the graphic waveforms. So by hitting that bar, then I restore my graphic waveforms. Okay. You have pressure, flow, and volume. The waveforms can be frozen for analysis. You can change the y-axis, or the amplitude of the waveforms, or the time frame of the waveforms. Okay? Now, once the waveform is frozen, then you can use the scroll wheel to move this red cursor bar to get various information about that breath that you froze. Okay, so here I know that the peak flow attained on that breath was 22.8 liters a minute at 16.8 centimeters of water pressure, peak pressure, and a peak volume of 492 cc's. Okay? The next panel is your parameter, your user-defined settings. And there's two ways to make settings. You can either touch the button, which activates the adjustment, and go up or down here with the adjustment buttons, or you can use this scroll wheel and then confirm. You have to confirm the change by either hitting the green check mark here or the accept button here. Okay, and then that accepts the change. If you don't acknowledge the change you've made, then it reverts back to what it was settled. It never completes the change. Okay. All right, let's talk about the modes that are available. Now, on the STD and the Vision, you had two modes, CPAP and ST mode. Okay, and those modes are certainly available on this ventilator. Okay, with two new modes added, which is pressure control ventilation and AVAPS, or average volume assured pressure support. We'll talk about each one of those individually. In the CPAP mode, there's very few settings to have to make. It's a simple mode. Okay, so you have your CPAP level. You have a ramp on here. Now the ramp, a lot of times patients that are using rather high levels of CPAP to mechanically stent open their airways to prevent obstructive sleep apnea when they go to sleep may complain of that flow blowing in through the nasal appliance. Okay, I can't go to sleep. I can't go to sleep with this blowing. So you can set the ramp for off, which means instantaneous, or from 1 to 45 minutes on this ventilator. So if you have it set at 45, it'll take 45 minutes for the machine to actually reach the 10 centimeters of water pressure. So it starts off at 0 for a few minutes, then it goes up to 1, it stays there for a little while, then it goes up to 2, and it just very slowly ramps its way up to the set CPAP level. Okay? We very rarely use that in the hospital. There is a new adjunct on this device, and it's called C-Flex. Now, the Respironics devices are noted for their algorithm, their triggering and cycling algorithm that's called AutoTrack. And AutoTrack is one of the best methods in the industry to know when the patient's in an inspiratory phase and when they switch over to the expiratory phase. It can really keep up with the patient. Now, say I have a high CPAP level, here's 10. The analogy is I'm driving in a car, sports car, at 100 miles an hour down the Autobahn. And I roll the window down, and while I'm driving, I stick my head out the window, and I have a 100 mile an hour wind hit me in the face. Now, when I open my mouth to take a breath in, boy, that's easy. 100 mile an hour winds flowing down my airway, and breathing in is easy. But now I got to breathe out. And I'm breathing out against a 100 mile an hour wind. Well, how hard is that? Kind of hard. As I'm trying to blow out, there's air blowing back in. Patients can become uncomfortable with that, and you may see them activating or using their accessory muscles of exhalation. They're like they have to force the air out against that incoming flow. If that's becoming a problem for the patient, I can go to the C-Flex mode and have a setting of off, meaning that I get constant CPAP, both inspiration and expiration, or I can set it to level 1, level 2, or level 3. What the C-Flex does is it takes the foot off the accelerator at the start of exhalation. So it eases out that flow so that the patient can begin to get their expiration flow out, and then by the end of exhalation have attained its CPAP pressure. Okay, so there's never a big drop in circuit pressure. It just makes it easier for them to begin their breath out. Okay, so what kind of patient should I use this on, and what setting should I use? I don't know. You just have to play it by ear or adjust it for each patient to their comfort. Okay, but it's there for you, and it's a good mode. Then I have the FiO2 control. This is a proportioning valve. It is not, there's no onboard analyzer, so this is not a measured FiO2. So you'll have to get an external analyzer, attach it here. either just leave it on all the time, or at least when you're doing vent checks, validate your FiO2. Make sure that's what you're getting. Because I could have this hooked up to an airflow meter, 50 psi. It knows there's 50 psi going in, but it doesn't know what it is. Okay. So if it was air, I could say give me 50%. It's giving me 50% of that pressure, or that flow from the wall source, and 50% from the internal, I call it the blower. But it's not guaranteed that that's a true oxygen concentration. So analyze it. Okay, now I've made all the changes as a batch. I've done them all at once before I've accepted the mode. Now I'm going to accept the CPAP mode, and now I'm in CPAP. So I'm going to have to breathe for it. Okay. Then here I have my alarm settings. Make sure your alarms are appropriate for both your patient and the mode that they're in. Meaning, don't just max out your high alarms and turn off your low alarms. Okay, it's a hospital setting. They need to be appropriate alarms. If something happens, we don't, have have an extra liability with them. Okay. Any questions on CPAP? All right. Next, we have the ST mode. This is pretty much the mode we think about as being BiPAP. Okay. So I have a IPAP, or inspiratory positive airway pressure setting, and an EPAP setting. Okay, which is the PEEP. Think about that as the PEEP. The difference between those two settings is your level of pressure support. Okay? Silence that alarm, reset it, and I get my waveforms back. The IPAP, by definition, should always be larger than the EPAP. And rule of thumb is that it should be at least 4 centimeters of water pressure greater than the EPAP. Okay, I usually would set that starting off at 5 centimeters of water pressure and go up from there. Okay, whatever pressure support they need to get a good tidal volume. Now the rate is the respiratory rate for the timed breath. So the ST mode means spontaneous time. So the patient can spontaneously trigger pressure support breaths, or the machine will automatically set the rate based on time. Now here I have a rate of 10. The minimum rate I can set is 4. Okay, so the backup rate for adult patients is typically 4, and for PD patients can be much higher than that. So it needs to be appropriate for the patient. Now, at a rate of 10, every 6 seconds, the machine looks to see if the patient has triggered a spontaneous breath. If they have not, then the machine will give them a machine breath. Okay? Now, on the machine breaths, it matches this I time that you have set. So make sure that that's appropriate for the patient. On their spontaneous breaths, they can have whatever I time or flow that they desire. They set their own I to E ratio for that breath. But on a timed breath or a machine breath, it must have this I time, so make sure it's right for the patient. PD patients may go 0.4 seconds to 0.8 seconds. Adult patients will typically be 0.9 seconds to 1.25 seconds, maybe 1.5 seconds. You cannot exceed a 4-second I time on this device, okay? There's a rise here. Rise is like C-flex in reverse, so with that active, I can turn that to 1, which is the fastest rise time for the inspiratory flow, meaning that the flow comes in really fast to get the airway pressure up to the IPAP level as quickly as possible. So that would be a square pressure waveform, okay? If the I time is kind of short and the IPAP is set fairly high, then the flow has to be so fast to get that in that it can get kind of physical to the patient. It's kind of like it's slapping them with flow. Sometimes you can even see the inspiratory limb jerk, okay? Probably not a good situation. So we can reduce the incoming flow or the acceleration of the flow and make that more gentle, kind of slow it down a little bit at the start of inspiration with a setting of 1 through 5. Now 5 gives you the slowest and therefore maybe the most comfortable inspiratory flow rate. But if I accept that, then I've cut off a significant portion of the area under the curve of the pressure waveform, so my volume is going to be lower. Okay? I'm losing volume by providing comfort. So one of the ways to combat that is to increase your I time a little bit to make up for that cut-off edge, okay? And they'll restore their volume. There's a ramp available on this. I don't know of any situation where you want to use it. Usually, if we're starting this up, we needed it an hour ago. Okay, not let's wait 45 minutes for it to get to its iPad. Okay, so now I'm going to accept that mode, activate that mode. Now I can look at the indicator bar here, and a time breath is orange, but a patient triggered breath is teal. So you can kind of, even from a distance, kind of get a feel for how much the patient's participating in their ventilation. Okay. And then I would want to set my alarms appropriate for this mode. Next mode we have available is called pressure control ventilation. That's what it is, pressure control ventilation with a non-invasive ventilator. Here again, it looks like the ST mode. I set the IPAP and the EPAP, the rate, the I time, the rise, ramp if I want to use it, and FiO2. Now, in this case, it's really important to set the I time appropriate for the patient, because every breath that the machine gives, whether it's patient triggered or time triggered, will conform to this I time. Every breath will be the same. Whereas in the ST mode, or the SIMV mode, you could consider it that, the patient can set their own I time on their spontaneous breaths. They cannot in pressure control ventilation mode. Every breath will be the same as far as I time goes, so make sure you have that set right. Okay? This would probably be appropriate for patients that are under some sedation, and so their spontaneous breaths are kind of not much effort being put into them, so they're not drawing a lot of volume. And so until they wake up, I can assure good ventilation with this mode. Okay. The last mode I want to talk about is called AVAPS, and that is average volume assured pressure support. So for the first time on a BiPAP machine, I have a tidal volume setting on it. Now this is a target tidal volume. So think of AVAPS as pressure regulated volume control on the Servo I or the Avia. Okay? So it will monitor what pressure it's given and what the patient's tidal volume is. And if that volume is not achieved, we'll adjust the pressure until that volume is achieved. Now, with the Servo I and the Avia, the pressure increases or decreases by 2 centimeters of water pressure per breath until the desired volume is attained. The V60 is a little more conservative in what it does. In fact, it will adjust the driving pressure by 1 centimeter of water pressure per minute until the volume is achieved. Okay? So I'm going to activate this mode. Have a rate of 10 set here. It's starting off at a pressure of 16. I've got 322 cc's volume. So is that close to my 500? No, it's not. So I'm going to start watching my pressure increase here, but it's not going to do it fast. Okay? So now I've gone 3 breaths in this mode, and I'm at 377 cc's at a pip of 17, and I want a volume of 500, okay? So it's going to take me a while to get there, and the doctor may say, no, this is taking too long. So there are some things that we can adjust to more quickly affect the volume that the patient's achieving. One of that's called the P-min. This is the starting point for the pressure support level in the AVAPS mode, okay? So if I'm not getting where I need to be at what it is set at min, I can increase that. So we'll go up to 20, let's say, here. And I can increase the I time if I spend more time area under the curve of the pressure waveform, and so that will increase the volume that's achieved on each breath. So now I made those 2 settings, the P-min and the I time, and now within 2 breaths, I'm going to 3 breaths. Okay, at 3 breaths, I actually hit my volume, and I overshot it. So now we're going to start seeing the peak pressure drop until it drops back down to the 500. But it's going to take a while, okay, because it only makes a change of 1 centimeter water pressure per minute, okay? So if I want to, now I'm saying, oh gosh, now I'm at 600, that's too much. Well, first I can decrease my I time. okay, and see what kind of change that has on the pressure, on the volume. Okay, so now I started dropping it there, but not fast enough, so now I can take my P min and let's drop that down to 15 and see what happens. Okay, well, like anything in PRVC, it's never quite perfect, is it? Okay, so I dropped a little bit too high. What I'm going to do in this case is just bump up my eye time to 1 second, and that should get me about as close as I'm going to get to 500. But I didn't have to wait a long time, several minutes, for that to adjust by pressure, because I'm affecting the eye time in the minimum pressure that it starts out at. And we'll watch it for a minute or two. I might have to make some other adjustments. Now, when you start the therapy on the patient, you've got to put them on an interface, on a mask, okay? The Respironics systems would prefer that you use Respironics mask, of course. And regardless of what size this mask may be, this is a medium full face mask. Here's a small nasal mask, okay? And here's a kind of an alternative to prongs, okay? Cannula type interface. But regardless of the size of the mask, they all have a number on them. So don't throw the bag away until you look for the number, okay? In this case, it's the number 1, and it's the number 1 on this one, okay? So they both have the same number. Now that's a leak indication that the machine, it's a code for the machine to know what the leak is in the system. So remember, on the vision, before you started therapy, you always had to do what was called the exhalation port test. So you'd occlude the airway, put the whisper valve on, occlude the airway, and hit the start button, and you hear the flow ramp up. Okay? Well, what was that doing? It was putting flows at various rates through the whisper valve so it could figure out what the leak was and know what the leak was when it was ventilating the patient. Okay? You don't have to do that on the V60 if you're using Respironic equipment. So you go to Menu, Mask Port, tell it that you're using an interface that has the number 1 on it, and accept that. And then it says, what kind of whisper valve are you using? And that is the Respironics disposable valve here. So I dial that in. That is, and it even shows me a little picture of it. Accept that. Now it says, okay, that's all I have to do. Okay? It is distinguishing what the patient leak is from the leak in the whisper valve, and it knows exactly what the leak in the whisper valve is. Okay? So it says there's no leak here. Well, can you feel a leak there? I can hear a leak there. There's a leak there. Why is it saying 0? Well, what the V60 is saying is, I know what this leak is, so I'm baselining it. And I'm zeroing that out. So now whatever leak you see here must be coming from the patient. The nasal mask isn't on tight, or their tracheostomy tube is a little leaky, okay? And so whatever leak I report is coming out of the patient, not out of the whisper valve, okay? Now, many times you get patients that come from home situations where they have these machines, and BiPAP machines or CPAP machines at home, and they want to use their interface. It's the one they're most comfortable with because they've had it for years, okay? And most often that is a ResMed mask, because they had, in the day, they had a very nice gel cushion seal on it, so it was real comfortable. So the doctor will write the order, a patient may use their own interface, which is fine if they're clean. But trying to mix a ResMed, see, a ResMed mask has its exhalation port built into the mask. It doesn't use a whisper valve, okay? So we have to let the machine know that I'm using something that it's not used to. So I go to my mask port, I go to mask type, other, and then remember that the ResMed mask has its own exhalation port. So I have to tell it that it has the other too. Okay, it says, wow, wow, you're really throwing me a curve here. In order for me to know what to do with leak, you're going to have to do an exhalation port test, just like with the old Vision. So, okay, we say, fine, we can do that. So we'll disconnect the patient. It's not going to do anything until you disconnect the patient. Of course, you wouldn't have connected them yet until you've done this, okay? All right, detects the patient's off. And now it says, okay, occlude the circuit and start the test. Occlude the circuit and start the test. This bar comes up, and we'll hear it ramping up the flow. Boom. It says, okay, now I know where I'm at. So we can start ventilation. All right. And we're off to the races. But notice here that instead of saying patient leak, it says total leak. Okay? So it's not vouching. It knows that there's a leak there, but it doesn't know what's coming out of the mask, out of the exhalation port of the ResMed mask, and what's coming out of the patient. So it's just going to report it as a total leak. Okay? Right. Now in this situation, we'll say that I've got a patient with a trach. All right, and I'm using the disposable valve, and accept that. And now I go back from total leak back to patient leak, because it knows what's coming out of its whisper valve. Okay. Okay. Any questions on that? Different systems have different leak numbers on them. So this device has you plug in the number 3 for it instead of the number 1 like you would on the other mask. Okay. Your patient may need to be transported, but not on the V60. Okay, surgery. They're going to surgery, and the surgical teams come, and it's right across the hall, so they're just going to kind of bag them on the way over. So you don't need to take the machine. Okay, so let's put it into standby. Now the standby mode in the Vision was pretty clunky. It often would fall out of standby and start alarming, and the nurses would unplug it and shove it over in the corner, and you say, "Hey, why'd you turn my machine off?" Because it was alarming. We couldn't make it stop. Okay. If you just walked by a room and glanced in there and looked at the circuit funny, it would fall out of standby and start alarming. Okay? So they've improved that in the V60. I press my standby button. The V60 says, I'll be glad to go into standby, but not as long as you've got a patient connected to it. Okay? And it can detect that there's a patient there. So I disconnect the patient. The flow comes out as normal. Then it ramps down and it goes into standby all by itself. Now, one of the problems with the old Vision was if you jostled the circuit, or you dropped it, or you kicked it, or whatever, then it would fall out of standby and start alarming, disconnect alarm. So this is obviously much more robust. Okay, it's not going to fall out of standby. It's not perfect though. You can fool it. If I tap on the there, see, it fooled it and fell out of standby. So it's not perfect, but it's certainly better than it used to be. Okay. Now when you come back, then instead of having to hit buttons or anything like that, just connect the patient, and it detects that they're on there and resumes ventilation. Okay, pretty nice. Thing in menu, if you are going to transport with patient, you may want to hit the or press the screen lock. So now while I'm in the elevator or something and hitting it with, I'm not making changes on the ventilator, to get that out of the screen lock, just press the green check mark. Okay, and then I'm active again. Okay. All right. Are there any questions? That's all we've got. Thanks for your attention.